Good morning, friends. I'm sorry I'm not able to be in Jaipur in person. Some audit happening in the hospital today. And Dr. Joshi with kind invite. The topic given to me is rehab in Parkinson disease. As we all know, Parkinson disease was coined by James Parkinson 1817 as a shaking palsy, but it exists for years and thousands of years. Its incidence in the population North India ranged from 1700,000 and in South India to 3,100,000. And a lot of terms are there like Parkinson disease, Parkinsonism, Parkinson's plus syndrome. The main issue is these people will have extrapyramidal syndromes, and they can have additional features in Parkinson's plus syndrome, more of midbrain involvement in progressive supranuclear palsy, or sometimes because of vascular Parkinsonism, because of multi-infarct state, these patients can have additional features also. So Parkinson disease per se, classically present with bradykinesia, rigidity, and tremor. These are the motor symptoms. At this time, some patient can also have mild pain, fatigue, or minimum cognitive impairment. If you trace the history back in the prodromal period, some patients, now people say it's from the gut. Some patients have chronic constipation. Some patients have hyposmia or depression before they're diagnosed as Parkinson disease. As it progresses, we have new non-motor symptoms start coming in, like bladder problems, orthostatic hypotension, dementia. They are started on medications, mainly levodopa, carbidopa. They can have new complications like dyskinesias and fluctuations of bradykinesia with the on-off phenomena of Parkinson disease. In 15 years' time, 10, 15 years' time, they will have newer symptoms, more symptoms of posture instability, freezing of gait and falls, with dysphagia coming in. And even 20 years post Parkinson diagnosis, they must be having high doses of levodopa combination, and new symptoms of psychosis will also come in. Surgery starts and progress in future. The history of treatment of Parkinson's disease in 1899, it was told that just live in a keep quiet environment. In early 1900s, some stretching chairs, stretching exercises were done. 1975, the breakthrough when they first have the carbidopa combination, which changed the outcome of patients with Parkinson's disease. In 2000, there are new studies showing a lot of effect of exercise, some on neuroprotection also. And if you can see the literature, the medication in red line, a lot of papers are coming in. DBS came in late 90s. So many studies are there on DBS in the last 20 years. And exercise induced neuroprotection, neuroplasticity in PD in the last 20 years, again, a lot of papers are coming in, which means exercise both has a role in managing PD symptoms, but also has some modulatory effects as a neuroprotection in person with Parkinson's disease. What is ICF model? See a patient with Parkinson's disease, he will have impairments, activity limitations, and participant restrictions. The common impairments are motor, bradykinesia, slow movements, tremor, stiffness, rigidity, and lack of balance. Non-motor symptoms like pain, mood disorders, cognition problems, reduced biological drive, memory, and sleep issues. These impairments will cause problems in walking, communication, swallow, dressing, grooming, toileting, transfers. And then we have participation problems in vocation, social gathering, travel, education, which further depends upon the person factors, the environmental factors. PD care involves a lot of people. There are multiple deficits. A neurologist diagnose, psychiatrist, physiatrist, physical therapist, occupational therapist, nutritionists, and so on. It's a very long process. But always remember, it's a family-driven, patient-centered program to help such patients. To assess PD symptoms, there are specific scales for Parkinson's disease per se. Most common is UPDRS scale, which is quite big, mainly used for research. But most common clinical scale is Yoin and Yard scale, called as HNY scoring or grading for PD. There's the Ariad score, there's sleep scale for Parkinson's, Scales for non-motor problems, MOCA for cognition, GDS for depression, work balance. You have solo-specific index for Parkinson's, and decisive assessment for patients with Frank-Eye assessment scales. These are required to assess baseline problems. It is to do it yearly to keep track of such patients. How to plan rehab? Primarily only motor deficits, simple scale, HNYR scaling. The stages 1, 1.5, 2, 2.5, 3, 4, 5. Stage 1, unit involvement. They only require flexibility exercise and education. 1.5, you will add postural training and track exercises. When both sides are involved, add strengthening training and endurance training. When you do a pull test, people have recovery on pull test, viral disease, add balance training. When you have more postural instability, you to main more exercise, start gait training also for them. When they severe disability, start gait aid training. And then stage 5, they're wheelchair bound, they will require preventive rehab to maintain current level of functioning. Basic outline how you can prescribe exercise in patients with Parkinson's disease. See deficits per se, motor deficits, typical bradykinesia and rigidity. They will need range of motion exercises, aerobic exercises. Resistance training also helps. Strengthening exercises, dual task training. And a simple technique called as LSED big, which was initially started for speech therapy, is now also being used in bradykinesia to improve the range of motion of all the joints and to prevent bradykinesia and rigidity in motor deficits. Gait is typical features. They have hypokinesia, causing decreased step length, decreased speed, decreased coordination, typical fascination with increased cadence, freezing of gait. They will require a lot of flexibility exercises, strength training, endurance training, balance training. Reviews tell us that treadmill training is helpful in patients with PD and helpful to improve gait parameters. There is a study from Niman's Gupta's group which has also showed similar results. And external cue training, very helpful. You can do a somatosensory cueing or auditory cueing, which will bypass the basal ganglia, and then walking becomes a cognitive task. Very simple strategy can be used. We'll see in detail how it can help such patients. So to summarize, exercise part of Parkinson's disease, what types of exercises, aerobic exercises, strength training, balance agility training with multitasking, a lot of work on Tai Chi now, a lot of work on yoga now, a lot of work on music and dance. All four are helpful for this component of balance, agility and multitasking, plus stretching. Recommendations are do two things in one day. You do aerobic and strength on one day or balance or stretching on one day. So all I done at least thrice a week, at least 30 minutes as a protocol to prevent the worsening of disease. Some more guidelines coming in. Simple example that is a normal person with a black curve. If he does some more exercises, you can have better striatal dopamine. And if you're a person who is progressively worsening with Parkinson's disease, you add some exercise early, you can just have to delay. But most of the effects are on symptom modification, not much proven for disease modifying effect per se, but some papers are coming in to show there's some difference now between these two groups, between red and dotted line. So exercise helps physical fitness, reduce UPDRS scores, reduce non-motor symptoms, improve axial symptoms, better quality of life, better disease modification. But remember, falls are a problem. Cardiac risk also. These are elderly people can also have cardiac issues. Do some testing before starting exercise program with patients. Also, compliance is also poor in many people. So to classify into 3 stages, in early stages of PD, shortly after diagnosis, make a baseline, patient education, start the exercise program, and then the mid stage, fall starts coming in, put something called as functional mobility training. Teach them how to stand up, how to go to washroom, and how to come back. Mostly falls happen at this time. That will require 3 training training, sit to stand training, bed mobility training, and flow transfers training. Teach them exercise, teach them sequencing, and start environmental changes to prevent secondary problems. In late stage, people are becoming stage 4 and 5. They need equipments like wheelchairs, bathroom equipment, hospital type of bed, lift transfers, teach them caregiver training, and start pain techniques for better quality of life. A lot of technology has come up in the last 5, 10 years. Or robotic assisted arm training have some role to play in UPDRS 2 and 3 type of patients in an outpatient program. Training on lower limb robotics, again, UPDRS 2 and 3 have better cadence, have better gait speed, better balance with the 1 month intervention. Dynamic posture graphy is also helpful to improve bug balance score, prevent fall in such patients. Using virtual reality, very in thing these days, has had some benefit in maintaining balance and reducing falls in such patients. But what's coming in more and more is XR gaming, which is using Microsoft Kinect or V Balance board at home. That has good role to play again in maintaining core strength, improving balance, and prevent falls in patients with PD in done at home with the caretaker being around with the patients. External cueing is a very, very important concept. You can give a visual stimuli to bypass. You can give a auditory stimuli by a bell or a vibratory stimulus. You can give a somatosensory stimulus to bypass. All three can be used. This can bypass basal ganglia to get to the motor cortex and cerebellum, and patient can actually walk better with this technical strategy. Cerebral walker is there. It's called as visual cueing devices. This is called the U-step walker, which is a reverse braking system. Just like we have airports, we have these trolleys. It works very well to prevent falls in such patients. The laser device to guide the somatosensory input, also simple device with simple auditory feedback to improve the feedback of auditory cueing and visual cueing in such patients. There are actually machines available. There are customized devices being available. Very common strategy is called as metronome, which is called as rhythmic auditory stimulation. With music you can try, or you can actually in US you can buy these devices, which are stimulatory devices to give more commitment to the patient to prevent fall in Parkinson's disease. Technology is coming up. It's helping these patients to maintain the level of functioning in the community. RTMS, very common thing in these days for most of the neurological problems. You're giving high frequency RTMS to the involved part of the brain or low frequency the opposite part of the brain. Both have shown some better gait and motor scores. But again, how many sessions to give, we don't know currently in the research, not so used for clinical practice. Same way, TDCS, simple device, current stimulation to the brain. Again, how much to give, how many times to give, dosing still we don't know, currently used in research at present. Next up, dysarthria. People have difficulty in producing sounds. The motor speech system is affected. Can be slurred speech, can be slow speech. The common plot dysarthria in Parkinson's disease are these two. One is hypokinetic dysarthria. People are speaking slowly. The rigid musculature, which is around the speaking apparatus. There can be hyperkinetic dysarthria, and people have involuntary movements, and that cause fluctuating type of sound, which comes very fast. So both are possible. Initially, they have hypo, then they turn to hyper with time, with the medication effects in such patients. There are 90% of patients have dysarthria at some time in Parkinson's disease. Problem issues are reduced loudness, monotony, hoarse voice, breath quality voice, reduced articulation, and you can understand their speech many times. Those strategies being tried, the most common approach are called as prosody-based approach to improve the outcome of speech. Also, LSPT loud, which is to speak loudly to pronounce words, also helps in such patients to improve articulation, better training their speech. Music is also being used to help patients to speak better rhythm, which also helps. Also, the machine called as speech amplifier, which can be worn around the neck, and it can improve the speech threshold by about 5.1 decibel in patients who have hypophonia in Parkinson's disease. Then people have dysphagia, the difficulty in swallowing. Then many of the advanced PD come to hospital with a aspiration pneumonia. You can do a simple three-finger test to swallow, with a very simple protocol to assess the dysphagia, their cognitive status, motor status, language status, check all the cranial nerves, do parallel trials, and then find out what stage is involved. Is it the oral stage, the pharyngeal stage, or the third stage being involved? You can do a simple cartoon, you can possible dysphagia, no clinical testing is fine, start feeding, affected, you start instrumental evaluation. and you can do a modified barium swallow, fluoroscopic swallow study. You see the food goes straight here into the esophagus, comes in front here, within the vestibule, comes further down, with aspiration. We all have fluoroscopy in our X-ray units, can use them to help our patients. And to for rehab, active approaches, first the compensatory maneuvers, which are postures. You can use different postures, change the consistency, try blended type of food, not a hard or liquid food. You can try rehabilitative techniques like LSVT, EMST, or electrical stimulation, or you can start some maneuver, specific maneuvers like Mendelssohn maneuver, Bethel technique to improve the sensory input for the patients. Now, this is called as vital stim, which is electrical stimulation of swallowing muscles. White people doing swallow therapy training, which is now very useful in patients with dysphagia and Parkinson's disease. And even advanced PD can be benefited with this training if it is combined with conventional swallow therapy techniques. People have tracheostomy sometimes, advanced PD, don't worry. They want to speak. You can just do a simple dye test and then put a small valve, a one-way passive speaking valve, with that they can speak with the tracheostomy to prevent aspiration or sometimes empty, with the quality of life. Cognition and behavior also being involved, start from minimal cognitive impairment to advanced cognitive problems. People with Parkinson's disease care to have cognitive problems. One is cognitive impairment without dementia. Third is with dementia. Both can happen. Do a full psych assessment to find out which component is being more involved. This will cause more disability, more caregiver strain, less quality of life, more caregiver requirement actually. Cognitive rehab has to be tried to improve cognitive skills. Attention control has to be improved. And you can also start some medications like mementin, donepezil, or rivastigmine to improve cognitive function in such patients. And these people also have depression, fatigue, and apathy, which sometimes requires SNRI input to a pharmacotherapy or a lot of exercise to improve such symptoms. Pain, it's a big problem in many of the advanced stage of Parkinson's disease. Pain can be because of MSK issues, rigidity, and comorbidities. Dyspnea causes pain. They can have age-related neuropathic pain because of regular problems, central pain. People also have akathisia and reduced sleep with this is leg syndrome. All can cause pain. Just to make it very simple, continue stretching and arm exercises to reduce tight muscles, use ice post therapy. Many people have very painful frozen shoulders that will require a combination of both botulinum toxin for pectoral muscles, the suprascapular nerve block to improve the range. They can use the daily activities. Many people are walking with their very tight hamstrings, which causes a crouch. Need one toxin for their hamstring muscle to improve their mobility. Also remember, advanced age will cause simultaneous spondylosis, osteoarthritis, which requires aggressive treatment to maintain mobility in such patients. In advanced stage, people will have a lot of problems. They lose their independence. Even at this stage, inpatient rehab is very, very important because many patients, when they are losing their mobility, they come to the hospital with either aspiration pneumonia or a UTI, and then they start worsening. They spend 2 3 weeks of inpatient rehab, which they can regain their mobility back, which is very, very important to prevent secondary admissions in such patients. And when they are becoming very, very more disabled, they will require a lot of AAC techniques. Simple low-tech AAC can be used. A simple EEG-based device can be used, or you can use EC units, which are also available now to modify the environment as per your requirement. Don't forget palliative care. People who are bedbound, a lot of caregiver stress is there. The patient has a lot of pain, distressing symptoms, and we have to provide them good quality of life and quality of death also. And the concept changes at this stage. Treatment is mainly to provide reduction of nausea and vomiting, reduce pain, reduce breathlessness, improve constipation, reduce rigidity. And don't forget, people will die ultimately. They will require end of life care support and bereavement support also in such patients. So just to summarize, this is a framework study which has come recently. What to do when? There's a moderate evidence to show that physical therapy, occupational therapy, and speech language therapy, soon after diagnosis, has good outcome. And there are three framework of pathway for rehabilitative care. First is called as consultative proactive rehabilitation. Soon after diagnosis, give them patient education, treat early deficits, good patient education, and start exercise programs to prevent worsening of disease. Second is called as restorative rehabilitation, stage 2, awareness stage, actually 2 and 3. When people have functional deficits, they will get a lot of functional training. All those four components of exercise has to be started: aerobic, tai chi, strength training, balance training. And third, the skill maintenance rehabilitation for long-term monitoring of exercise, meaningful activities, safety, contracture, skin indication, preventive rehab, dysphagia, dysarthria, treat them well to prevent the worsening, keeping them as mobile, walking, talking as possible. And fourth stage is the palliative care stage, when these patients require home care and support. Again, the guidelines from APTA on therapy interventions in Parkinson's disease, the high evidence for aerobic exercise, resistance training, balance training, community-based exercise, especially exercise gaming, gait training, especially on treadmill gait training, task-specific training, integrated care. Tele-rehab also is coming in now in Parkinson's disease, especially for home monitored exercise, as a weak evidence at present. Also remember, there are some contributors to poor outcome, which are mainly four. First, cognitive problems. Teach them theory of problem solving, dual task training to improve cognitive functions. The non-motor problems like hypertension, very commonly missed. Give them stoppings, binders, start me routine so if required. Treat apathy and fatigue both by exercise or exercise if required. So these medications, mainly all dopamine drugs can cause dyskinesias, impulsivity of motor fluctuations, which will cause problems in long term. And don't forget the comorbidities. The people are aging like all of us. They can have depression, cognitive impairment, secondary medical problems like diabetes, mellitus, hypertension, heart disease. They will be on polypharmacy. These also worsen with life. Keep we can optimize all these things, then provide good rehab, make them as mobile as possible. Just to summarize, patient will have symptoms of motor symptoms in the beginning. They meet the neurologist, then the investigation starts on pharmacotherapy. At the same time, they will start developing stage 1.5 and 2. They need active disease management, prevention of complication, start training for physical exercise, cognitive problems, communication problems, and then symptom control. And then some people will worsen with time, some people worsen early. To start palliative rehabilitation also at this time. So neurology, rehab, and palliative care, and as rehab physicians, we have a role to play in all three stages to help our patient to provide continuity of care. And that's how a rehab need will change from stage 1 to stage 5, and they have a role to play in all these stages in life cycle persons with Parkinson's disease. Thank you very much.